I'm going to talk briefly about an alternative gene therapy for HIV. A number of technologies that prevent HIV replication in infected cells have been developed. These include RNA decoys, RNAi, transdominant gene products, and fusion proteins. The difficulty in translating these technologies into a clinical setting is modifying a sufficient number of patient cells. This is also true for gene therapy in general. Most gene therapies for HIV aim to downregulate or delete the CCR5 co-receptor. The potential of downregulating the CCR5 co-receptor is based on the results of an HIV-positive leukemia patient who received a 100% ablated bone marrow transplant from a CCR5- donor. That patient has remained HIV negative without antiviral medications. An alternative gene therapy approach for HIV/AIDS is to overexpress the CD4 main receptor and/or CCR5 and CXCR4 co-receptors on cells non-permissive to HIV replication. The rationale is that these cells will remove more virus from circulation than other cells without making additional virus. This approach significantly decreases the number of patient cells that need to be modified. The same vector used to express the receptors can be used to render the cells non-permissive to HIV replication. I will show two simulations that compare CD4 T cell loss when a percentage of patient CD4 T cells have been genetically pre-modified. Several variables are incorporated into the calculations. Cells that do not express CCR5 have a selective advantage in an HIV environment. For the simulations, these cells are considered to be refractory to HIV infection. Cells that are non-permissive to HIV replication do not have a selective advantage. When these cells are infected, they are eliminated from the population. The average half-life of an infected T cell is 1 day. There are 10 to the 11th CD4 T cells in the average person, about 2% of which are in circulation. The virus spreads slowly. Each infected CD4 T cell produces enough virus to infect 1 to 2 additional cells. This is an accepted range. I will use a value of 2 in the simulations. The number of uninfected CD4 T cells that are killed is greater than the number of infected CD4 T cells. The exact reasons for this are not entirely known. These cells are typically referred to as bystanders. I will use a ratio of 10 bystander cells per infected cell. In this simulation of CD4 T cell loss, 50% of the patient's CD4 T cells have been modified prior to HIV exposure to downregulate CCR5. The rate at which the modified T cells repopulate is proportional to the percentage of the total number of CD4 T cells. In this simulation, the modified cells are being lost faster than they can repopulate. Most CD4 T cell loss associated with HIV/AIDS occurs during this stage of the infection. This simulation starts with a much smaller fraction of pre-modified cells. This is closer to the level of modification you could expect with a systemically administered gene therapy vector. Downregulation at the co-receptor at this level of pre-modification has no effect. However, increasing CCR5 expression on the pre-modified cells reduces the number of CD4 T cells lost. A similar effect is predicted to occur during latency. From a practical standpoint, T cells are difficult to modify in vivo. Less than 0.1% can be modified using a systemically administered HIV-1-based gene therapy vector. Dendritic cells are also targets of HIV infection. These cells express high levels of co-receptor and low levels of CD4. About 1% can be modified with a systemically administered vector. Hepatocytes and endothelial cells can also be modified to express CD4 and the co-receptor. These cells are naturally non-permissive to HIV replication. Hepatocytes can be modified very efficiently with systemically administered AAV and HIV-1-based gene therapy vectors.